that was, as Nicola Roxon said, rolled gold, and her presentation was rolled gold. It was energy dense, and there were so many important and useful messages in that presentation. I might say a couple of comments. She mentioned the importance of speaking with a single voice. She mentioned overweight and obesity as an issue where there was not a united voice from researchers and health groups. Interestingly enough, as a result of her comments, the Obesity Policy Coalition led an initiative to actually get a consensus document on obesity, overweight and obesity. Brilliant piece of policy work. That was done several years ago. But guess what? Despite having a single voice on overweight and obesity issues with a wonderful consensus around a series of policy initiatives, still nothing has happened. So I think it's not just a question of speaking with one voice, but many other factors as well. One other thing, reason why Nicola Roxon is one of my superheroes is something that she doesn't get much credit for. Tackling Indigenous smoking. I was at the AMA many years ago, and we said to the Minister of the day, one of the three big drivers of the life expectancy gap is tobacco. And we asked for a substantial investment in a dedicated campaign for Aboriginal and Torres Strait Islander people. I went to Nicola Roxon and said the same thing. And she says, how much money do you need? And I said $100 million over 5 years. But that's what she did. She invested substantially in addressing Indigenous smoking. That is now a policy that is bipartisan, and that substantial investment in Indigenous smoking continues to this day. And it's done wonders to reduce the incidence of smoking and disease associated with tobacco amongst Indigenous peoples. And that's something that she deserves enormous credit for as well as some of her other well-known policies, particularly plain packaging. Interestingly enough, she also talked about making sure there are no surprises. I'm now going to introduce our panel session. We have a range, a great set of panelists today. Felicity McNeil, Managing Director at Perspicacité and Chair of Better Access Australia. Felicity has extensive senior management experience in Australia's health regulatory and subsidy sector. She spent 5 years as head of the Pharmaceutical Benefits Division, responsible for Australia's PBS program, life-saving drugs, and special access schemes for oncology, diabetes, and stoma. And she was awarded the very prestigious Public Service Medal, the PSM, in 2016 for her work in reforming the PBS. Interestingly, she has also headed up the Office of Health Protection, which covers public health, pandemic and communicable disease management, an issue of great importance before she was appointed as CEO of the Organ and Tissue Authority, a joint Commonwealth and jurisdictional initiative. Today, she's the Managing Director of Perspicacité and Executive Director of Due Diligence Australia. She's a former President of Hepatitis Australia and current member of the Consumer Health Forum and the Australian POP Association. Paul Cross, Director of the Daily Dispatch. He's a former is the founder and director of Daily Dispatch, including 3 leading mainstream publications covering Australia's pharmaceutical, biotechnology, private health and medical devices sector. He is the founder of the BIM, a social media platform for the Australian life sciences sector, an experienced and senior executive in the US and Australia, and former federal government ministerial advisor. And also joining us today, I'm delighted that we have Louise Hardy, National Policy and Government Relations Manager at Arthritis Australia. Louise has considerable experience in government relations, particularly from her previous role at the Royal Australasian College of Physicians, and she has worked at New South Wales Health in various roles in health practitioner regulation. So we have our panelists with us. The questions are open to you. The first question I've got is an interesting one and focuses on a comment made in the opening session today by Katie Allen about the importance of respectful persistence. Nicola Roxon also touched on this important process about how you conduct your engagement with politicians. So I'm going to ask each of the panel members, what is the most common mistake made by patient organisations in their advocacy work. And we might start with you, Paul.
Thanks. I think the most common mistake is taking advice from politicians. I think respectful persistence, whatever it was fine. What about respectful listening? I mean, politicians, ministers, they're elected to serve the interests of the community, and that includes patients, not the other way around. I've heard some interesting things today, which honestly sit uncomfortably with me. I'm a little bit confused as to how a patient group that's working off a kitchen table and has no experience in advocacy is meant to know the ins and outs of lobbying. I think it's the job of a minister to get their head around what a patient group is talking about and advocating for, not the other way around. I think respect is really important, and everyone's got to do their interactions and manage their interactions with everyone respectfully. But I think politicians and government need to look at how they show respect for patient groups before they start demanding it.
And how might that happen? Don't tell me there should be some form of empathy training for politicians in this space.
Right, I think, well, there is an APS code of conduct. I know it doesn't apply to politicians, but we live in a system where patient groups are openly threatened for advocacy. So I am deeply disturbed by what happens these days, and the way patient groups are spoken to, and the way they're dealt with. And I don't limit that to elected officials. I think Nicola Roxon was probably minister in a bit of a different time. And I did work for 2 health ministers for 6 years. They're coalition health ministers, so my my politics is pretty clear. But I do think I'm pretty worried by what I see and what I hear about in today's decision making.
I think you make a really important point, and treading carefully. And there is a fear. There's a palpable fear, I think, amongst many organisations. They don't want to upset the minister because they don't want to be pushed off to purgatory forever. And I know some ministers and politicians, Nicola Roxon alluded to it, have very thin skins and long memories.
And isn't it disturbing that any stakeholder group in Australia is concerned over the consequences, the potential punitive consequences of exercising their right in a parliamentary democracy? That I think is a serious problem.
Putin-like power.
Yeah.
Felicity, could we get your perspectives on this?
Yes, look, thank you. And look, I completely agree with Paul on this one. One of the reasons we started Better Access Australia was because we're not reliant on government in any form for funding, whether we run programs or whether we are actually looking for support to continue our advocacy. And it was because we were volunteering with individuals on a day-to-day basis, trying to get help to understand the system, to be let in, being told how they'd been spoken to, completely contradicting. I'm going to completely contradict Andrew Lee, saying, come and talk to us about an individual drug. Don't talk to us about the system. It's too hard. Actually, no, it's my system. It's my health system. And that's the problem. The reason patient groups are walking in and competing against each other is because the system is driving that and demanding it. And I'm absolutely with Paul, respective listening. If you listen to the community, if you listen to what's happening, the system is actually, it takes a lot of advantage out of putting patient groups up against each other, competing against each other. We talk about the in club and the out club. I'm a former bureaucrat in a federal system. I do understand how when I'm controlling the money, that means there's a certain fear. That fear is egregious to me. And it's an incredibly powerful tool when someone's sitting in front of you and they're scared that their money's going to end on 30 June, or they're scared that their money might go to somebody else. We have to be very careful about that. So I'm with Paul, the respect has to go both ways. And you know what? There's nothing wrong with standing up. I looked at the document that Andrew mentioned on gender advocacy that talks about, don't be argumentative. Don't say what you think. I'm sorry, we owe a lot to Grace Tame. We owe a lot to the fact that she has actually explained to people that it is your system, that you do have a right to be heard. And you don't always just have to sit there and make someone else feel good about the fact that they gave you 10 minutes of their time. You actually are there, it's your health system. Very, very important. And I think it's not about empathy training. I think it's about, we've had a couple of years of COVID now, and it's been very easy to put people onto Zooms and to put people aside. I think with the election coming, it's a very important opportunity for us to demand better access for patients for that respect, and to be comfortable. You should feel comfortable disagreeing with someone, just as you do in your day-to-day work. And I guess the other thing I'd remind people is we're talking with a very federal focus here right now. And dealing with the federal system, both the politicians and the bureaucracy, is different to dealing with the state system. Different ways of interacting, different treatment, different access. And my experience is a lot more respect. So that's my starting pitch.
Thank you. Both Felicity and Paul, you'll certainly hit a note with our delegates today. A lot of people are applauding you loudly. Louise, Felicity mentioned the in club and the out club. You know, what's your perspective and take on this? Do you have to work hard to be on the in club, or you know, as an organisation representing me, as someone living with psoriatic arthritis, you know, I'm really pleased that you do that on behalf of people like me. And but what do? Are you prepared to go on the barricades and charge, or are you trying very hard to be in the in club?
So look, I mean, those were some really important comments from the panel. I think, you know, in practical terms, what do you do with that? I suppose, you know, there are some organisations that are in the in club by, you know, virtue of the fact that they represent very powerful interests. I think as a consumer group, you know, it goes to that point of having a strategy behind what you're doing. And so thinking through in advance, you know, is there a time and a place to go public with my concerns, but, you know, understanding what the consequences are to that. And I suppose, you know, when you're taking a more private approach and you're trying to have those constructive discussions, it's, you know, being prepared for the counter offer and kind of understanding where your red lines are, particularly if you're working with other organisations. What's, you know, what can you negotiate on, what's a non-negotiable, and where do you go from there?
Someone on the chat said it's a catch-22 for groups without funding, the out club. It is difficult to manage the system without support for small patient organisations. Paul, what could be done to better support the small patient organisations that, as you say, the kitchen table approach? What could be done to give them more voice?
Well, it's almost an intractable issue. Now, you know, I think obviously the government can do more to give people a voice, but it's got to be no strings attached. I mean, it's, you know, when I was a ministerial advisor, I mean, you know, I think it's really funny. I've always been of the view that when government tells you that media campaigns don't work, it means they do, because they wouldn't need to tell you they don't work if they didn't work. I think the idea about going about your business quietly and respectfully is nice in theory, but when you're in a minister's office, you're dealing with 1,000 rolling disasters, and the squeaky wheel gets the grease. So I would just say that you might go about your business quite quietly and respectfully and stay out of the media and meet all the criteria set by some politicians, but 100 other groups aren't doing that. And the idea that you shouldn't go and have direct contact with a prime minister or another politician who could influence the health minister, to me, that's just crazy, because that's the whole basis of lobbying and advocacy. Now, for small groups, I think it is really hard, because the government limits its money and its grants. It shows obvious favoritism in the way it does it. And when it does give grants, let's make no bones about it, it uses that money. I think the current minister has been incredibly effective in shutting down groups with things like national action plans. So these are a few $100,000 to develop a national action plan over a couple of years, which in the end the minister barely endorses and doesn't get any state and territory buy-in, who actually are the jurisdiction that deliver health services in this country. Now, with all due respect to those action plans, because I know a lot of work goes into them, it's pretty transparent what the government is trying to do with those. So there has to be, if there is going to be money from the Commonwealth or from governments to support these community groups, which I support, they've got to let them. They've got to also give them the freedom to operate and do what's in the best interest of their patients. And I think in health, we have sort of developed this view over the years that groups have been trained to think that you shouldn't advocate and you shouldn't be assertive and you shouldn't be aggressive. If I want to get a stop sign at the end of my street to protect some kids, I will aggressively assert my interests to the local council and my elected representatives to get what I want. And that's would be my job as a community advocate. And I would dare any of them to tell me not to do that. But in health, we seem to be in this environment where everyone's told to stop advocating and stop expressing your interests. And it doesn't exist anywhere else in government. And I just think it's really, I find it really offensive when politicians are speaking to patients in that way. I just do not like it at all.
Felicity, just reflecting on Paul's comments, I remember a good friend of mine, he retired as a CEO of a major health regulatory body. He gave a great speech when he retired, and he said there's two things that make Canberra work. One, it's all about the money, and two, the squeaky wheel gets the oil. He said it's terribly tragic that that's the case, but that's how Canberra works. Is that how Canberra really works?
It does in a lot of different areas. My experience is broader than health. So health is much more political, and it varies by ministers. If you have a minister with a vision, Nicola Roxon, I served under Nicola Roxon, I've served under both sides of politics. She actually did have a vision for something she wanted to achieve for the health system. Michael Wooldridge, who Paul worked for, I was in finance then, so he drove me nuts because he spent a lot of money, but he had a vision for what he wanted to achieve in the health system. What the moment we're dealing with the current minister is a minister who is driven to politically control the bushfires, to make health not an issue, which can be great if you want some money comes out, but it also means that it does react to this. I think there are things that are systematic that the system needs to reform, or system, to actually stop this. So, for example, the grants funding. This is something that was reviewed by Finance 12 years ago, and it was supposed to change the fact that small organisations need to invest in health workers, they need to invest in the patients that represent and advocate, and they can't do that when you cut their money every 12 to 18 months to 3 years. But the concept behind that is that then you shouldn't make everybody be competing at this last minute, and I have to take you down to make sure that I get that money. We've lost the sense of that. We've also, when there's been budget cuts, been the first thing to do is to take percentages out of the grants funding and leave that to a side. And so patient groups have had their money taken away from them incrementally. And that's been very disempowering. That's a systemic reform that is needed, particularly in health, to allow the delivery of these services, to allow patient groups to advocate, to represent who and what they're trying to do. So I think that's the first really important point. The second thing is, yes, the money does talk in respect of, I declare my conflict. I'm frantically trying to get national newborn screening for 80 diseases so that when you've got the drugs, you can actually be screened for them so that there's a benefit to the children and the adults that might need them. But I can use that massive money like in the MRFF, and I can do research projects. It's like national action plans. If I do a research project, I can stop everything for 2 to 3 years because I can't do anything because I'm waiting for the evidence. That's a really dangerous trap for organisations. Sometimes it's wonderful to have the research money, and some things really need it. You've also got to be careful that I use the money to buy your silence. Here, go and do the national action plan. Here, go and do this. Some of the work that's done under those research funds and those action plans is really, really important, but it doesn't mean that you don't keep doing what you're doing, and it doesn't mean that you don't keep supporting others in your space. And I guess that's the one other thing I would sort of say with the money talks thing. The system wants you to compete against each other. Be kind to each other and be respectful publicly and privately about the other organisations. That's really important. When we see language like astroturfing, we have to call out that behaviour, we have to support each other, and we have to make sure we're not replicating those things elsewhere in the patient groups.
Louise, Felicity talked about competition amongst patient organisations and health groups, what, from your perspective and your experience, you know, what mitigates against working together, and what should we be doing to actually cooperate more?
That's a good question. I think I've generally had quite positive experiences of working with other organisations, and I think possibly, you know, when your kind of cause is altruistic sometimes, or when you've got broad agreement across different groups of what you're trying to achieve, that obviously makes it a lot easier. Look, I think it does come back to kind of, you know, understanding what your different roles are, and, you know, what the level of cooperation is. You know, there are some organisations that, you know, you'll be in touch with, but you won't necessarily be sharing everything. You may have kind of slightly different strategic objectives, and then others where you work hand in glove. So yeah, I think it varies a lot, but my experience has generally been pretty positive.
Thank you. Paul, we've got a question here. Given what we've heard about the number of issues that MPs and ministers pitch day in, day out, and you know, they come in at the rate of 10 an hour, and the amount of money that they're asking for, what are the factors that guide prioritisation and or the filtering process that staffers and advisors go through? And what tips do you have for patient organisations? You know, what are the things that get, as a ministerial advisor, get you excited or your minister excited about?
Well, that's the key point. What I would say is I think the name, the ministerial advisor title, is a bit misnamed. I was talking to Felicity about this recently, actually, because really you're sort of a glorified inbox. Is that your power is proximity to the minister, and then that comes down to the relationship you have with the minister. I work for two ministers, one who is not reliant at all on their advisors except to run interference against stakeholders. So your job essentially comes down to you know, as one of protective, and you're also protective of your relationship with the minister. If you have a good one, you want to protect it. So naturally, you're going to triage things that you know are of interest to them. And health is a portfolio where you are constantly in the budget process, constantly engaging other ministers if you're doing your job properly, and constantly having to make decisions if you're doing your job properly. And so it's actually quite hard to elevate. This is why I think, you know, your respectful engagement, as it's been, you've got to be respectful, but you've got to get your issue to the top of the pile. And the thing that gets the issue to the top of the pile is risk. You know, because ministers are constantly calculating risk. Now, Greg Hunt has been incredibly effective politically in shutting down the portfolio and stakeholders in the portfolio. And we can have a debate about whether or not that's good. I suspect it's not. But that's a real challenge in an environment where a minister spends an enormous amount of time trying to shut people down. It's going to be very hard to elevate issues. You see the National Medicines Policy Review at the moment, which is one of the most Soviet processes you can imagine, where like stakeholders have gone to any amount of trouble to make submissions and they've just been completely ignored. So they talk about respectful. It's like, well, how about you respect these are patient groups that don't have a lot of time, they don't have a lot of money. Most people aren't doing it full time, they're doing it on a volunteer basis, and the government's just completely disrespected their input. That to me is really problematic. So how are we going to correct that? The only way you're going to correct that is by putting pressure on the minister. And it really is as simple as that. And that can take any number of forms. Go and see the minister's colleagues, go and see the opposition, speak to the media. It's a simple thing. People talk about advocacy and they complicate it. It's actually a very, very simple thing. You just got to get your issue to the top of the pile. And in the current context, that's not an easy thing to do, but it's like all advocacy. Other politicians, other stakeholders, media, all those ingredients that work.
So Paul's suggesting, if I interpret him correctly, that we should really be no more Mr. Nice Guy. We should be much more forthright in our advocacy. We must push the issues harder, and we shouldn't be afraid of using the media to do so. Felicity, are there any caveats to that advice?
Well, Paul was explaining about the fact that you should feel confident in your messaging. You can still be respectful, but assertiveness is important. I mean, one of the reasons we at Better Access Australia often come out on things or sit on a podcast with Paul and talk about things is I know that because the patient groups that are struggling to sort out their funding, sort out the programs and are so beholden to the system, They need that philosophical discussion taking place so that they can walk through and actually have a conversation. When you're a big, strong organisation or a big, strong patient group, and there are smaller ones in the system, and I saw some of the comments being told that you're a cottage industry. I mean, whoever said that and had that said to them, I sincerely apologise, and shame on the person that said it. Because patient groups are about the use of the system. It is your health system. So if someone's not listening, that's what we do. Paul talked about stop sign. I talk about trying to get my child healthcare when something's going wrong and she's in the hospital and I think something's happening. I don't sit there and sit respectfully saying, if someone could just talk to me, please, that'd be really great. Look, if you could just get back to me when you can. That does not happen. So by all means, we start on a process, but the system relies on you going, yeah, you'll just push back, you'll just push back. But sometimes you have to take a stand. So being clear in that. So I really agree with Louise. If you've with Nicola Oxon, if you've got a clear objective and you know what you want to do and you've got the evidence to support you, and whether that's your own anecdotal evidence or some massive study because you've got funding to do some big research paper, that's great. But the next step is then, if I push back on you 3 times, I'm a health system, and as a bureaucrat, I used to rely on the fact that if I just keep doing this and delaying you, in the end, most people give up. Whereas the people that get through are the ones that have to keep going. And I know that when I'm pushing back as a bureaucrat on people who are doing this as a part-time or volunteer space, there's only so much they can do. So yes, if someone's not listening to you, you talk a little bit louder, please. And media isn't disrespectful. So media is not disrespectful. Comments aren't disrespectful.
And if you, I think in my playbook, you know, as long as you play the ball and not the person, you're on sound ground. But politicians, nonetheless, some of them have incredibly thin skins, and even they think if you play the issue publicly, it's a personal affront.
And they need to grow up, and we need to actually more collectively work together, and we need to support each other. So, for example, today Paul wrote the story about the program, and I'm going to use it because it's a real life issue for people online right now. There is a program that's going to end on 30 June that benefits so many people on this Zoom. So it's our job as another patient group to turn around and say, that's not good enough. Stand up and defend these people. That's the difference in the media system for me, which is it's not just about our own issue, it's also about calling out the behaviour and the support for others in the system when they don't have a voice.
Patient pathways. And in fact, I was amazed to hear Katie Allen support it in very vigorous terms. Perhaps some hope there. Louise, there's a question for you here. What are some of the areas where Arthritis Australia works well with government, and what areas are constantly challenging for you?
So area where we've worked well, so we do have an action plan, which, you know, it was a piece of work that we worked on for many years.
But go away for 2 years and come back.
You know, it's described as a snake swallowing a wombat, our organisation swallowing an action plan and a couple of grants that were associated with that. But, you know, that is something that, you know, got a lot of issues that we were trying to get up for a couple of years on the agenda. So we were happy with that. And we've obviously had an ongoing relationship around some of those issues. I think, you know, one of the recent issues that's been a bit trickier has been around medicine shortages in the COVID context. So there have been arthritis medicines that have been used to treat COVID, or there's been shortages for other reasons involving the global supply situation. And so, I mean, that's turned out well in that, you know, we've worked with pharma and with the TGA and the clinical groups to kind of, you know, develop new processes and support consumers through that. But I guess it's an example where there's no easy answers, and where, you know, consumers have been going through a difficult time, where some of them have had to change medicines that were working for them at long last after, you know, trying and failing on other medicines. So yeah, look, that's been a more difficult issue. And I think in my previous roles, you know, in the College of Physicians, you know, we worked on more contentious issues such as asylum seeker policy. And, you know, I suppose that's an example where you kind of, you know, you have a choice about sticking to your principles and knowing that, you know, you're going to upset the government if you do go public in some way. And you know, you've just got to decide, you know, I suppose internally as well, getting, you know, your internal processes and your board on the same page as you, getting, you know, making sure they have the same risk appetite that you do, and that they kind of understand where you're going and why you're doing the things that you're doing, so that you can kind of have the confidence to see it through.
You mentioned risk appetite, Paul. You know, perhaps what constrains patient organisations is not just the fear of retribution or upsetting the minister or upsetting the department and getting in the out club rather than the in club. But what do we do? What about our own internal checks and balances are? What happens if we have a board that where the risk appetite is not strong?
Well, Felicity's probably better placed to answer that, given she was the president of Hepatitis Australia. What I would say is that I just recall. I mean, I'm going to show my age, but there was no social media when I was a ministerial advisor. There was a very plonky, outdated version of clips, and I think it's still in existence actually, where you go through the media clippings every day. And I have to tell you, every time I saw something about PBS access or a particular drug or a treatment, it absolutely bugged me no end, and it annoyed me. But that's the job. That's the job. That's the job. The job is in that office and in that portfolio to manage all of that. And just because it's happening doesn't mean it's wrong. Some ways, this is the only way organisations can communicate their message. And Felicity mentioned the patient pathways issue, where Greg Hunt has ignored 3 pieces of correspondence from the organisation, and the officials are treating this organisation with a complete lack of respect. To me, the risk is not doing something about that. That's the real risk, because if this is allowed, not just with this program, but if this Soviet mindset and the treatment of patient groups is allowed to institutionalise, then we are in serious trouble with our health system. It needs to be more responsive to patients, and it needs to start doing that by just treating them respectfully and not talking down to them.
Maybe we need to follow the lead of the Consumer Health Forum and set up an advocacy academy for patient organisations. We've got 2 minutes left. I'm going to go around the panel and ask for one key message you have for patient organisations to get the cut through needed to drive change. Felicity.
Keep going. We rely on you giving up. The bureaucracy and politicians rely on you giving up and being too tired. So please keep going and support each other.
Yes, Rob Moody famously said the successful advocacy relies on 3 things: persistence, persistence, persistence. Louise.
I think probably just understanding what makes these people tick, as in the decision makers that you're going to see. And this session's obviously been very helpful in doing that today. But yeah, understanding where they're coming from and what their drivers are and how you can kind of hook into that with what you're trying to get done.
Thank you. And Paul, the final word.
Trust yourselves. Is that any issue is that a patient group that you're pursuing almost certainly outweighs the discomfort that it will cause officials or government. It is their job to manage that and to be on the receiving end of that. And if they don't want to do it, then they can go on to another job.
Thank you very much indeed. We've finished smack on 1 p.m. This has been a really energising session. I thank all our panellists and speakers today. Lots of things to think about, lots of things to chew on, but a very clear message for everyone. Get out there and do it, and don't worry about the niceties. So thank you, everyone. And I look forward to the rest of the conference. The first 2 sessions today's been great. And I think the opening session was great. And I think it bodes well for the rest of the conference. Thank you.